Okay, ladies.
Good evening, and welcome to session one of the Camellia Rose chapter of the Links Incorporated Breast Cancer Awareness in Women's Health Discussion. We are delighted to have Dr. Rosberg Phillips Reed and Dr. Contessa Metcalf to share with us as panelists this evening. Dr. Rosberg Phillips Reed is a native of Georgia. She's a general surgeon that specializes in breast surgery. She's a graduate of Columbia University School of Physicians and Surgeons and Emory University. She practices at Metro Surgical Associates and has been in practice for over 38 years. She is very passionate about women's breast health and founded Sisters by Choice, a nonprofit organization that offers support to women being treated for breast cancer. Welcome, Dr. Phillips Reed.
It is indeed.
Dr. Contessa Metcalf is from Kansas City, Missouri. She graduated from Xavier University and received her medical degree from St. Louis University School of Medicine and completed a residency program at Morehouse School of Medicine, master's in public health, preventive medicine, and occupational medicine from Meharry Medical College in Nashville, Tennessee. She is a part of the Bravo hit television show Married to Medicine. Dr. Contessa feels that prevention is the key to healthy living, and she has seen the effects of breast cancer and will share her story with us this evening. Welcome, Dr. Contessa.
I
Our moderator this evening is Ms. Lolita Browning Jackson. Lolita is a member of the Camellia Rose Links chapter and is an award-winning journalist. She received a mass communication degree from University of Tennessee at Martin and an MBA degree in marketing from Clark Atlanta University. She is the owner of Four Cs Consulting, which is a full-service external affairs agency specializing in government and community affairs. So, Lolita, you may begin.
Thank you so much, Angela, and Dr. Phillips Reed and Dr. Metcalf. Is so wonderful to have you both. And I will just jump right in with the first question. I'm going to start with Dr. Phillips Reed. Please just share with us and describe what is breast cancer.
breast cancer. First, let's see. Say what is cancer?
What is cancer? Okay.
What we cancer basically is not something that's foreign from your own cells. What happens when you develop a cancer? What your normal cells have gotten a signal to change. They mutate or change their growth pattern, and they start developing abnormal cells. These abnormal cells grow and develop and continue to develop. One cell develops two cells, it multiplies into four cells, it develops a lump. And so when you have a lump, we call it a tumor. And a tumor can be either benign or malignant. If you have a benign mass, the mass just kind of sits there and it slowly grows. And as it grows, it doesn't spread from one site to another. It just pushes your normal tissue away. Cancer cells really invade your normal cells, and it also pushes the tissue away, but it also can spread from one site to another. So when you have breast cancer, it is an abnormality that develops in the breast, and it has the potential to invade not only the surrounding breast tissue, but spread from one site to another.
Thank you. And so I want to go here. According to the CDC, Black women and white women get breast cancer at about the same rate, but Black women die from breast cancer at a rate that's higher than white women. Why is that? Would you explain a little bit of that for us, please?
There's many different. It's a multifactorial thing. It's not any one particular thing. And I am one of the doctors who believe that cancer in white women is the same as cancer in Black women. If we look at the stage that Black women most often present, They present at late stages, and late stages is difficult for us to control and treat. In addition, it's no question that we have triple negative breast cancer, which is more prevalent in African American women, but white women get it also.
Mhm.
And it all depends on the stage. When we look at successful treatment of breast cancer, we always have to look at the stage. It doesn't have to be a culture thing. When we look at the statistics that we see and what we can do, early detection, better quality treatment, and also being preventive. We know that mammograms save lives, but we also know that there are certain areas throughout the country where we don't have quality mammograms. And when we look at these areas, they're mostly in, low income areas, in minority communities. And those are things that we can easily do something about. So it's not only, the type of cancer that African American women get, it's the stage that they're being diagnosed, it's quality care. And it's also, we have to change a lot of the myths surrounding breast cancer in African American women. We have still a lot of people who believe that the treatment that we have, it kills you. They don't want to do it. They don't want to do chemo. They don't want to do radiation treatment. And if we look at stage to stage with African American women and white women, if you get the same treatment, stage for stage, quality treatment, our expectation is that you'll have the same outcome. So we have to encourage our women to, number one, embrace the mammograms. If you have something going on in your breast, don't be afraid to come forward and be evaluated, and embrace the standard treatment.
Thank you. And I want to talk more about mammograms, but first, I would like for Dr. Contessa. You made a big decision to do preventive surgery. Would you please share your journey with us and that decision, how you came about that?
Yes, ma'am. So interesting. My mother actually had her first bout with breast cancer when she was in her mid-20s. And then ultimately ended up having breast cancer a couple of times after that, and passed away in 2010 from breast cancer at the age of 53. But her first time was in her mid-20s. And so I've been getting mammograms essentially since I was in medical school. And I've had so many mammograms. I've had abnormal ultrasounds. I had abnormal MRIs. And so actually, I was lucky enough to have TRICARE insurance when I was in the military. And someone was super smart and referred me to a geneticist and said, hey, maybe you should get some BRCA testing. Well, I had a mutation of undetermined significance. And what's interesting, and I'm sure Dr. Phillips can talk about that a little bit, but a lot of times, even my girlfriends who are my age, people who've had cancer may decide not to get genetic testing. And it's really valuable to get that, because for the people, we know about BRCA1 and BRCA2 mutations, but there was actually a class of Jews that participated in the study, and that's how you found out about it. But there's a lot more mutations that are out there that we just don't know about. And so when I had this mutation of undetermined significance, the genetic doctor said, you know what, you should talk to your mom and see if she'll have the genetic test and figure out if you have the same mutation that she does. And that would make it very, very concerning. Well, my mom said, in the name of Jesus, we're not going to worry about that. And we're not going to do that test. And of course, as a scientist, I'm like, actually, you just made me worry about it even more. And she basically kind of sent me away saying, I don't know, shrugged her shoulders and said, I don't know if this is something, but we don't know what to do with that. And so with, the advent of more and more abnormal tests and kind of this thing hanging out in the atmosphere. And one time I actually had an MRI that showed an abnormality behind my right nipple. And so they were like, well, you know what? Let's send you to the breast surgeon. We'll do an ultrasound. And the breast surgeon was like, you know what? We're just going to watch it. We'll just continue to follow up with, it looks okay, but I don't know. Let's just keep watching. And so it just causes anxiety in me. And it's been there and had been there for, essentially a couple of decades. I always thought a boob's job is to nurse a baby. And so after nursing my 3 babies, I decided, you know what, they completed their purpose. And now all I do is worry about, whether or not they'll one day kill me. And so that's kind of what led to my decision. I felt like I was past the point where I needed to nurse a baby. They fulfilled their purpose, and I just didn't want to worry anymore. So that's what led me to that decision. And I was actually 42. And the last time I had an ultrasound after another abnormal mammogram, I said, I'm done. I am done. Let's consider this the beginning of my workup for my prophylactic mastectomy. And here we are today.
Thank you. Thank you. And so what, if someone has a family history of breast cancer, as Dr. Contessa experienced, when do you believe that someone should get screened? Like when should they start if they have that family history? And at what age should they begin getting the screenings?
I like to start, if I have a patient who's have a family member with breast cancer, I like to start 10 years earlier with a cutoff of age 25. And I look at that mammogram, and it's no question that when we look at mammograms in young women, mammograms really and truly does not tell the whole story. And I think it's more important in these young women to do breast examination and also do sonograms. But mammograms can give you some information that a breast exam can't. For instance, it can give you, abnormal calcifications. We look at both breasts. It tells us whether or not one breast looks a little different than the other one that we need to be concerned about. So again, family members with breast cancer is extremely important. And premenopausal breast cancer, as Dr. Metcalf had, her mother had her first instance of breast cancer when she was very young. Young women, the younger you are, the more likely you are to have a gene carrier, more likely to be a gene carrier.
Okay. Thank you. So we are getting questions from our audience, and so I'd like to address a couple of those. You mentioned earlier that with the comparison of Black women to white women and the triple negative. The question is, why do Black women develop triple negative more often than white women?
I don't think anybody can answer that. It's just a fact that it happens, and what we try and do is to make sure that Black women are aware that they are in a category where their breast cancer is more likely to be triple negative than a white woman. And they have to be very careful and make sure that they're doing the things to maintain their breast health.
Thank you. And so as we talk about breast health, are there symptoms that someone can experience that would detect them or make them aware of breast cancer?
Early breast cancer is usually, and I say usually, 99% of the time, is completely asymptomatic. And it's something that you pick up in a mammogram. When you have symptoms, a mass, pain, and pain really and truly, it's a minority of people that's going to present with breast tenderness and pain and end up with breast cancer. I should say end up with an early breast cancer. And we have to emphasize what we want women to realize, that your overall prognosis is directly related to the stage of diagnosis. So we want to be, if you're unlucky to get breast cancer, and I want to emphasize that all women, because of their gender, is at risk to get breast cancer. So no one is immune. I think some people think that because they don't have a family history of breast cancer, then they don't have to worry. And most women think that breast cancer happens to somebody else. It's not going to happen to me. And our attention is only drawn to breast cancer when a family member or a friend is diagnosed with breast cancer. And there's a great deal of fear, even to the point of sometimes not being able to reach out and support someone who's been diagnosed with breast cancer. But we have to emphasize early detection. So as far as symptoms is concerned, the majority of patients who are diagnosed with breast cancer is completely asymptomatic, without symptoms.
Okay, thank you. And we have another question from our audience, and that is to please explain dense breast tissue.
Dense breast tissue basically means that um, your breast tissue is very thick. You can't see through it. If you look at a mammogram with a dense breast tissue, it's almost a whiteout. And so abnormalities, are hard to see if you have dense breast tissue. The radiation doesn't penetrate to highlight those abnormalities. So that is one reason why we don't routinely get mammograms in young women, because their breasts are dense. Now, dense breast tissue is a relative risk factor for older women. The older you get, your breast tissue goes through what we call an involution, where your dense breast tissue transforms into fatty tissue. I mean, we all will see as we get older how our breast tissue transitions. So if I see an 80-year-old or a 75-year-old or 65-year-old with dense breast tissue, that's a red flag for me. And again, it's difficult for mammograms to pick up a lot of the abnormalities when you have dense breast tissue. So again, breast examination is more important in people with dense breast tissue, and supplementing it with mammograms. And depending on your risk factors, if you are considered high risk, your doctor may supplement that with an MRI. An MRI gives us a little more information than mammograms. It's very sensitive though. And so it can pick up early cancers that mammograms may not pick up.
Thank you. And as you talk about mammograms, we know mammograms are important and they have been able to pick up. And as you say, maybe sometimes they don't. So let's talk a little bit more about how someone can do home breast screenings, and what are some different things that they can do, but also what is it that they're looking for?
When you're examining your breast, and I teach my patients to do what I call breast mapping. I give them, a picture of breast and give them several, pictures, and I tell them to examine their breast. So what happens is that, when you're filling your breast, I mean, you're just trying to familiarize yourself early on what your breast tissue feels like. Your right breast generally feels like your left breast. So if you feel something, at 12 o'clock in your right breast, feel it the exact same area in your left breast. And also, it's important to be consistent with your breast exam. Do not examine your breast every day. I mean, that's, your breast tissue changes throughout the month. So I recommend that you, if you're having your cycles, examine your breast 10 days after your cycle. If you're not, just select the time of the month that you're going to routinely examine your breast. I examine my breast the 12th of the month, every month. Just because my birthday is July the 12th, and you guys can remember that if you want to, and send me something. But every month on the 12th, that's when I examine my breast. So key thing is being consistent with the time, and feel your breast with light touch with your tips of your fingers, and not try and be very rough and examine it and trying to pick up every little thing with your breast. But again, you will realize if you examine your breast, jot down in your own words, not in medical terms, jot down in your own words what you're feeling. The next month, examine your breast, same time, jot down what you're feeling, and then compare what you felt the first month versus what you feel now. And then do it a third time. By the third or fourth month, you will have a good idea what your breast tissue feels like. And that is extremely important. And I've had patients who come in who examine their breast, and they'll say, Dr. Phillips, I feel something. And I will examine their breast and I don't feel anything. I don't ignore them. I listen to them. If they are routinely examining their breast, I will follow their breast. I sometimes get, depending on the age, or I'll get diagnostic mammograms or ultrasound and follow it. I have had patients where simply because a person knew their breast, they were diagnosed with an early breast cancer. So we as physicians listen to our patients. On the other hand, when someone walks in my office and they have a big lump in their breast, I know they're not examining their breast. And it helps us in trying to decide what is benign and what is not. if a patient comes in and they tell me, Dr. Phillips, I have been examining my breast every month, and I woke up and I felt this lump. If I feel this lump and it has all the characteristics of a benign mass, meaning a cyst, that's probably what a mass is that pops up, within a short period of time. So again, examining your breast, being comfortable and talking with your doctors about what you're feeling, it helps us tremendously in trying to maintain your breast health.
Yes, definitely. I always say we know our bodies better than really anybody else. So it's definitely good to do that. And thank you for explaining that. Dr. Contessa, I want to get back to you to talk a little bit about what you would share with someone else who is considering the same thing. But how did you get past, I guess, the personal connection to your breasts? Particularly in a relationship or having a husband, like how do you make that transition? I don't want to be so personal, but for so many women that is personal, and that's a big decision, particularly for preventive, if in the way that you did, but for those who also have had to go through reconstructive surgery after breast cancer.
Well, I will say, I don't have nearly. There was none of that trauma, none of that, those issues. I'll say that from the experience with my mom. My mom actually chose to get a lumpectomy with radiation. And I will tell you, it changed her. I mean, a lot of women, of course, we associate our breasts with our beauty. And so that disfigurement that was caused, because now I think they do a lot better with caring about the outcome of the physical appearance after the surgery. When my mom had her surgery, and of course, not being a woman of means, I don't think that anyone ever considered the end result when they did her surgery. They were just like, basically just be lucky that I'm doing this and I'm saving your life. So the outcome of whatever the cosmetic result is does not matter. And she felt embarrassed of her look, and it definitely affected her self-esteem. And so I will say the great thing now about even just how insurance works and how people are treated with breast cancer and that reconstruction being a part of the deal, I think she would have actually probably even been a little bit more aggressive with her treatment, and even been willing to even maybe follow up a little bit different. Because I do believe that alone, that result, the disfigurement to her breast, was just as traumatic to her as her breast cancer diagnosis. And that sounds funny, maybe to other people who are like, oh, breast cancer can kill you. But my mom was in her 20s. She was a young, vibrant, beautiful woman. And so for the rest of her life, she was very, very conscientious of her chest appearance. And it did affect her sexuality. Without knowing all those details, I can tell you she changed. Her personality changed. And she was, so one, that I didn't have any of that. I was lucky enough to get what's called nipple sparing. And it all depends on for a woman so again, my journey is different because I didn't have cancer. So it's almost just like I had implants. I don't have, my cosmetic result is exactly like no one, unless you knew me and you could see the scar underneath my breast, you may just think I had implants. And so I don't have any of that. As a matter of fact, I didn't get I've always been a small chested woman. And so when I had my surgery, the surgeon before the surgery was like, talk to the plastic surgeon and figure out what size you want. And I was just like, I don't care. I didn't even think about that. And it's so funny. Some of my friends will tease me. It's like, you didn't think about, you could have did a better job. You could have got bigger breasts or something. But for me, I went straight to implant. And so I had one surgery. And for women who, and so again, it changes the whole, a lot of women have to have several different surgeries, and a lot of women don't even have that option. And so again, that timeline is so traumatic for women. And so, we think about just the cancer diagnosis itself, but it's so much more than that. Mm-hmm. For one who's had been diagnosed with breast cancer, imagine losing a nipple because you can't have a surgery that allows you to keep it. And so even though when you're wearing a shirt, you may look the same, when you take it off, you don't. And that it's like a constant reminder. And so it's just it's so many different variables and so many aspects of your life that get affected, that it is so really important for all of us who know people who've been impacted by breast cancer and ones who've gone through the surgery and who are making those decisions, to not minimize when they're thinking about what they're going to do as far as the treatment, because that's a big deal, because there's a lot, just as much as we talk about breast cancer, the occurrence is very common. We also think about the survivors. There are a lot of survivors. And so if you are a woman who's had breast cancer, you're going to live, hopefully, a very long time. And so it is something that, when you're talking to your family or friends and they're spending a little bit more time thinking about, should I get a lumpectomy with radiation or should I get a mastectomy? And you just tell them, just like, go for the mastectomy. Why would you even worry about that? And that was actually my complaint when my mom's cancer came back. I was mad that she didn't get the mastectomy, because I said that would have saved your life. There's no guarantee of that. Mm-hmm. But in my head, if she would have just taken the thing off, but again, just removing a portion of her breast was a difficult decision for her. Mm-hmm. And if she didn't have to do it, if she could have just done like radiation or just only done chemo, she would have much preferred to do that. So just remember that when you say those things to people, because it can be a little insensitive, because you think about, again, yourself. And if you have one arm or one leg, that's how a woman feels when they have one breast.
Yeah. Thank you for sharing.
I want to say, and thank you for sharing your experience, Dr. McCaff. One of the things that we have to emphasize is that there's so many different decision making that you have to do once you're diagnosed with breast cancer. And you will get a lot of advice, and I emphasize that each journey is different. The only thing a person has in common with another person is breast cancer. But there's so many different aspects of breast cancer that impacts each one of you, and your journey is your journey. It's personal. The other thing I want to emphasize is that support groups have really and truly have a major impact on women going through, breast cancer. Talking with women who have gone through, had breast cancer, looking at their options, because I think when another breast cancer patient meets another woman, I don't care where they are, there's an instant connection there. All right. And that sisterhood, that is there is a bond that's very strong. And I think their support system, your support system, your family, immediate friends is so, so important. But it is important for women to get out of that environment and be in a different, environment, to give them the right to holler, scream, shout, do whatever they want to do. Women tend to protect the loved ones in their family. And so they sometimes keep things from, their husbands, their kids, because they want to make sure they're all right. But going through breast cancer is a life-altering experience, and you do change. And I think for the most part, I've taken care of so many women, and I think for the most part, majority of patients change for the better. You may think you're the best person in the world, but this journey humbles you and it makes you better. And I've seen people who come in and they're very introvert, and they become different people after their journey. And so I try and tell people to stay in the moment. Don't try and look, 10 years down the line. Deal what's right in front of you and openly deal with it. And I think, as you go through your journey, your strength, your belief system, everything changes about you. And I think I've become a better person because of dealing, with my patients. I think the person that I am today has a lot to do with, the people and supporting, my patients. They have made me a better person.
Definitely. Thank you for sharing that, and it's really clarifying that everyone has their different journeys. Everyone has a different journey, and you've experienced all of your patients' journey. So I can definitely see how that transitioned you. I have a couple more questions from the audience. One is it is recommended is it recommended that if you have a triple negative cancer, that you also have a hysterectomy?
Triple negative cancer means that your tumor is not sensitive to estrogen. Giving you estrogen does not cause your tumor to grow. So when you think about, the hysterectomy or the oophorectomy, there's no connection between your triple negative cancer and your uterus or your ovaries. So no, there's no reason to recommend either one.
Okay, thank you. That was specific. And so the next question from the audience is, what is a fibrocystic breast?
You hear the terms fibrocystic disease. All the baseline of all our breast tissue is fibrocystic, right? And there's a whole gamut of changes from mild, fibrocystic changes to severe changes. And it is not a disease, it's part of your normal breast tissue. What happens is because there is a constant inflammatory process in the breast where, your milk ducts are clogged and you develop, little cysts that you develop lumps and bumps in the breast. And sometimes fibrocystic changes is difficult to distinguish between a cancer on just physical examination. And that's when a different diagnostic tests are involved. So usually a patient will come or a woman will come to a diagnosis based on two things: clinical, meaning that they will have periods of time where they have breast pain and tenderness, they'll have recurrent cysts, and sometimes it is exacerbated by caffeine intake, or they'll come in with a lump in their breast that will eventually get biopsied, and then it will show fibrocystic changes in the breast. But fibrocystic in itself is not a disease process.
Thank you. Thank you. And so we've talked about cancer in the breast, mammograms, your personal screenings. And so let's kind of start maybe again, I guess you could say from the beginning. You've been diagnosed with breast cancer. Then what? What happens? What are the next steps? And I do realize in asking this question that everyone's journey is different, but please share with us, maybe some treatment options and just what happens after that diagnosis.
When a woman is diagnosed with breast cancer, there's a whole gamut of changes that go through, and again, based on how you were raised, your belief system, everyone is going to deal with it differently. I always say we come into a diagnosis with I say other garbage in our lives. I mean, just because you're diagnosed with breast cancer, it's not like, you're born or your life is going to end. Right? Mm-hmm. You have other issues in your life also to deal with. But immediately you're given a maze of information, and there is many decisions that you have to make. Sometimes confusing, other times less confusing. So it is important when you're diagnosed with breast cancer, your initial evaluation or your initial consultation with your doctor is to take someone with you. When you're sitting there and the doctor's talking with you about your cancer, things goes in one ear and out the other. It's not intentionally, but that's just what it is. You need someone that you can sit down later and say, hey, did she say this? Or is this what I have? Because it's really, really confusing initially, and you only hear what you want to hear sometimes, and the things that you don't want to hear, you block out. So number one, once a diagnosis of cancer is made, bring someone to your initial evaluation. Two, don't put on blinders. I tell my patients to holler, scream, kick, do whatever you want. But at the end of the day, You have to sit down and educate yourself about your cancer so you can make informed, good decision. There are so many women who are when they're diagnosed with breast cancer, it's almost like the sky is falling. I think education gives you give you what you need to make good decisions. And also, I think you have to believe, you have to have faith, and you have to always, always count on that faith and belief to get you through a difficult time. We use 4 modalities for treating breast cancer. For most people with early breast cancer, it's surgery. Depending on whether or not you do a lumpectomy or a mastectomy, you may end up adding radiation treatment. Chemotherapy is reserved for tumors that are large, tumors that are aggressive, and tumors that are usually not sensitive to estrogen. Anti-estrogen medicine is used when tumors are small, they're sensitive to estrogen, and there's no indication for chemotherapy. All people do not need chemotherapy. Over the past 2 decades, through research, through developing new drugs, we have redefined how we treat breast cancer, and we continue to redefine that. I mean, how we treat breast cancer, say 2 years ago, is different than what we do now. And to emphasize, we are giving patients less chemo than we have ever given, in the treatment of breast cancer. If we look back, several decades ago, every woman got the same treatment. That was chemo, radiation, mastectomy, chemo, radiation treatment, and just say chemo, radiation treatment, and mastectomy. That was the 3 things. I mean, they all got that. So now we have so many, options, and we try not to be aggressive or invasive if we don't have to. So again, educate yourself about what your options are. If you need a second opinion, don't be afraid to tell a doctor you want a second opinion. A lot of patients feel like, we're going to get upset with them. No, you need to do what you have to do until you get to the point that you feel you made the best decision for yourself. And I always tell people, when you make the right decision for yourself, you'll toss and turn all night, but when you feel comfortable with your decision, you sleep better. Okay. And that's in any decision making. Once you make that decision that's right for you, life, the light at the end of the tunnel starts shining on you. But again, it's a process that you have to go through. It's not easy, but education, getting a good support system. And you have 2 separate support group systems. You have your family and your friends, and then you have your doctors. And if you have to feel that your doctors is in your corner. There's a relationship that you create with your doctor. This is a long-term relationship. It's really a lifetime relationship. When you're diagnosed with breast cancer, we used to say, 5 years and that's it. No, we have to emphasize the patient. When you're diagnosed with one breast cancer, your risk for developing a second is increased. The risk factors for developing breast cancer is being a woman. That's why I said all of us are at risk of developing breast cancer, followed by increase in age. We're all going to get old. I don't care what we do. Followed by your personal history and then your family history. Those are the 4 biggies. Okay. And so when you fall into that category, we follow you indefinitely. So again, education is so, so important when you're dealing with breast cancer.
Thank you. I think you answered a couple of questions within that. So I will ask you about the age of screening and testing, because we've heard it kind of go up and down. At one time, it was when you're 40. And then in recent years, we've heard wait till 50. And then, for those of us Black women, we're saying maybe we go a little bit early. Where's your medical opinion on?
Yeah, and I will tell you, Dr. Phillips, the guidelines, and I follow the guidelines by the American College of Radiology and the American Society of Breast Surgeons. And we feel strongly that at age 40, if you're completely asymptomatic, age 40, you start doing your routine screening mammogram. And when I say completely asymptomatic, meaning that you're not at a high risk, you don't have a family history of breast cancer, you haven't had multiple breast biopsies in the past, and you and yourself has not had breast cancer. So again, if you're considered low risk, average risk, start at age 40 and get that mammogram every year. And people say, well, when do I stop? My question is, you got one foot in the grave. I mean, we are living old, much life expectancy is much longer than it has. I mean, my oldest patient is 100 years old, and it's really interesting. When she was diagnosed, I took care of her way back when, and she was diagnosed 25 years later with a second cancer on the opposite breast. At that time, when she was diagnosed with her first cancer, we were doing mastectomies with radiation treatment. That's what she had. And she was diagnosed with a second cancer. This is an educated woman who's on the touring circuit. She was diagnosed. She was 96 years old. She had a very early breast cancer, and her husband, who was 96 years old, he didn't want her to have surgery. So what we did, we just gave her some anti-hormone medication because her tumor was sensitive to anti-hormone. Fast forward 3 years later, the tumor started growing. We did her surgery. We did, at that time, we did what we call intraoperative radiation, which is she has one dose of radiation. All right. And that's it. And she's doing well. This is later,
Yeah.
So age, you really and truly need to continue to do your mammograms. If you are someone who, if you develop anything, we would treat. Okay. So we just really and truly need to emphasize to our primary care physicians and our patients to continue to do their mammogram. Over the past decade, we have started seeing an increase in the incidence of older women with advanced breast cancer. When I say advanced cancer, I'm talking about when they come in with a big lump, 5 centimeters in their breast, or when they have nipple discharge and someone is bathing them and they fill up their, see the blood on their nightgown, and then they feel their breast. I mean, it is difficult in an older patient to give them chemo. And so we have to really and truly continue to emphasize, early detection and how important mammograms are. If you're at high risk, I mentioned I started, 10 years earlier with a cutoff of age 25. And that's not to say I've never gotten mammograms in youngsters. I do, but I have reasons to do mammograms, and I emphasize how important breast exams are. Did I answer your question?
Yes, definitely. And one of the things you mentioned earlier when we talked about the comparison of Black women and white women with breast cancer, you talked about the myths or even just quality care, but you also mentioned the stages. And so I wanted you to basically describe what are the stages. Like you could get diagnosed in a later stage, and it may have impacted you a little bit more. So if you could describe the stages for us.
The stage of breast cancer starts with 0 to 4. And 0 is really a pre-cancer. We call it in situ cancer. And the overall prognosis for an in situ cancer, which is ductal carcinoma in situ, the overall prognosis, doing the right thing, is approaches 100%. So if you're diagnosed with ductal carcinoma in situ, this is stage 0, you should not have a fear of being treated. Stage 1 is when you have a cancer that is 2 centimeters or less. And we have stage 1A and 1B. 1A is when you have lymph nodes involvement. And 1A is when you do not have lymph nodes involvement. And 1B is when you have lymph nodes involvement. And then you have stage 2. And stage 2 are tumors that are greater than 2 centimeters. I'm sorry, 2 to 5 centimeters. May or may not have some secondary skin changes. These are your advanced cancer. And stage 4 is when you have tumor that has spread outside of the breast and the lymph nodes. They present with a cancer in the breast, and you may find out, by chest X-ray that you have a mass in your lung, and it turned out to be breast cancer. So that's metastatic breast cancer, or cancer that is spread from one site, from the breast to the lung.
Thank you. And we have a question from the audience. And that is, you were talking about treatments just a little while ago. And the question is, what is the difference between chemotherapy and immunology?
Immunotherapy, immunotherapy.
It's immunotherapy. Okay.
Yes. There's chemotherapy is basically medicine that we give in your vein, and it unfortunately destroys the cancer cells, but it also destroys, the normal cells. And so it's a lot of sometimes you have a lot of complications from the chemotherapy. But the chemotherapy, what it does, it really and truly attacks rapid growing cells. And so if we look at the cells in addition to the cancer cells that it attacks, that's why people lose their hair, because your hair is really, your skin, changes color, or your nails change color. The cancer cells, it's target to attack rapidly cells that grow rapidly, cells in your body that's growing fast and turnover. And like I said, it's your hair and skin are cell types in our system that really and truly grow fast. Immunotherapy it doesn't really attack your immune system, but it kind of targets your immune system to help fight the cancer cells. That's the simplest way to put it. And so there's two different mechanisms that kills the cancer cells. Over the past 10 years, we have utilized immunotherapy in many different types of cancer. Usually your cancer has to be associated with a particular gene, and that enhances its response to the immunotherapy. But again, you're fighting the cancer cells based on enhancing your own immune system.
Thank you for that explanation. I'm going to go back to Dr. Contessa and have you explain. So we know you've done the preventive surgery, and are you all clear? When I hear Dr. Phillips-Reed says we're all at risk, and I look at myself, I kind of don't have the family history, but I do have, an aunt and a cousin who experienced breast cancer. And so I guess my question is, are you in the clear, and how does that all work?
Well, I mean, after this surgery, it's actually, my risk is less than 1%. So, and fortunately, everything looked good when they did the pathology, when they looked at the cells underneath the microscope after the surgery, everything looked good. And so, of course, in theory, there's still some breast tissue there. In theory, cells are small, they're microscopic. So if there's any breast cancer that wants to grow in a kind of leftover cell that was left behind, because of course, so what happens is, of course, you have different layers, and my chest wall, if there was any breast tissue that's left on my chest wall, all it takes is one cell to grow aberrantly. So it could happen, but it looks, they got most of the cells away. They're all gone. So I think I'm okay. There was another factor that I would like to mention that also kind of contributed. My mother never knew who her father was. And so we didn't know anything about my mother's father's side of the family. And when you think about your risk, you think about mother and father. And so it's not just one side. And that also kind of, and then my mom really didn't, wasn't really close to family members. And so I didn't know like family history outside of my immediate family. So that also was another big, question. Say, for instance, her father's sisters all had breast cancer, and his mom too. That's totally different than my grandmother did, and my mom's mom didn't, but that was kind of a big unknown as well. And so just remember, when you're looking, don't just only look at your mom and your sisters, and your mom's, is not a maternal thing. It literally is, it could be either side. So it's just something for women to remember. And I know, it's an interesting culture that we live in as Black people. We have this kind of hyper superstition thing working that if you don't talk about it, it's not real. There's a lot of magical thinking that happens. And I grew up apostolic in the name of Jesus. I'm not claiming that. That is, sometimes things claim you, and not combating it and kind of being like a turtle and or even, ostrich, putting your head in the sand. That doesn't change anything. And actually, the key is information and not acknowledging things that we notice. I mean, Dr. Roderick Phillips can tell you, you'll sometimes have a patient who comes in and they take their shirt off and you're just like, you've got to be kidding me. Like, how long has that been there?
Yeah.
And they literally, you're looking at it and you're like, this is you have literally a cancer, that's outside of your skin. And when I say, I'm not exaggerating, some people literally will just ignore it. And that's something that in our culture, you can pray about stuff, but you should go to the doctor, and that 1 or 2 times a year when you go to your doctor, literally like explode on them, like vomit information, like tell them everything. And then the rest of the year, don't claim it in the name of Jesus, but you mention it all to me. And then we can sort through it. But not talking about it does not make it happen. And so that was, and even when I asked my grandmother questions about, because again, the older I got, and of course, being in medical school, family history, you always, whenever you're filling out those check marks about family history, I would ask my grandmother things and ask her stuff about her sisters and brothers and this and that. And they didn't want to talk. It was just like, that's their business. I'm like, are they diabetic? I don't know. We don't. What about high blood pressure? Do they take medicine for high blood? Has anyone had cancer? And we just don't talk about it. So it is good to exchange that information, because again, that's how we also see patterns. We see that your sister had it and your sister had it and everyone in the family had it. So this is maybe something, because there's a lot of familial things other than breast cancer that happens in people too. Yeah. And so if you just talk about things, you'll be so surprised. And again, sometimes doing things early helps to limit, what you can, how bad it is. My grandmother actually died from Alzheimer's, or complications from Alzheimer's. But for so long, we didn't want to talk about her memory problems. We didn't want to talk about it, and we didn't want to claim that. And now looking at our family history, and you talk to other people, it's a lot of people in my family that have Alzheimer's as well, my dad's side of the family. So there's something to be aware of. And now, again, I'm aware of that. And there are things that I can start doing early, some crossword puzzles, some mind things that I can start to, keep my mind alert and active, because, diseases sometimes don't skip if, just because you don't want to talk about it. So.
Yeah, definitely. That's important, especially in families, to discuss it. Before we move to close out, I do want to talk about healthcare for a second. And just really with this question, what are someone's options for medical insurance if they're diagnosed with breast cancer? Because after that, there's so many doctors and there's so much that goes on that they would need health insurance. And I know there are some organizations out there that are helping, but what are some options?
Yeah, there are some options, but you have to qualify for them. I want to emphasize to everyone who can afford. We're in an era that health insurance is not affordable for a lot of people. But if you can, please get insurance. I mean, we have a segment of our population who, in particular, young people who can afford to get insurance, but they don't. And I grew up in a family that my dad never believed in health insurance. We were kind of fortunate, because he was kind of one of these self-made people. And, every time we went to a doctor or went to the hospital, he paid cash. But, that's not the way it is today. And so I want to emphasize first, if you can, if your employer providing insurance, please get it. The emergency Medicaid, women's emergency Medicaid is available to women who are low income, who are diagnosed with breast cancer, and you can get it immediately. But again, you have to qualify. So everybody does not qualify. Most hospitals will have some kind of program that they will work with people who do not have insurance. And you just have to be willing to, to go in and let them know. When I have patients who do not qualify for Medicaid, women's Medicaid, I make sure that the hospital that I'm associated with, support them, maximum. But again, if you're making money and you're just hoarding it, but if you got money, you own a house, it's hard for us to take care of patients who have some, financial stability, but not a lot, and that's why I emphasize you people, if you can afford, to get insurance, please do, because it's not only breast cancer, it's any, unforeseen illness that you might have or your family might have. So we have to educate our Black communities, if you can get insurance, yeah, instead of going for your nails, save that money, because at the end, if you look at how much people are paying for insurance, and when you get insurance, try not to get the cheapest, because if you got a $10,000 deductible, it's almost like having no insurance,
Right.
I mean, and so what happens? You cannot access your insurance until you pay that $10,000. So again, I want to emphasize the state of Georgia and most states throughout the country does provide for emergency. Women's Medicaid, and that's the best that we have out here. And again, the different hospitals throughout the city does help us take care of patients with breast cancer. So I don't think I can say I've had a patient that I could not get some kind of resources.
And do not forget about, as far as preventative services, screening exams, things like that.
Yes,
You can always use your health department.
Yes,
Your county health department.
Yes, the health department, but again, you got to qualify. And so that's why I'm saying, if you can have some, financial, means to take care of yourself. You got to love yourself enough to say, I'm going to do this for me. And that's where it is, instead of saying, it's costing too much, but yet you can drive around with a Mercedes or whatever, help. I mean, it's about, being realistic in this time and this day and time. And yeah, if you can afford any type of, medical assistance, please, don't take it for granted, because a lot of the people that are homeless, people think that they're homeless because they're drug addicts and all. No, they got a hospital bill that really and truly ripped through all their finances. And had they just had that, security blanket for insurance. That's why they call it insurance,
Right.
The car insurance, you don't drive without it.
Right. Exactly. And so there are some resources that we do have. I believe our producer here is going to show some of the resources that we have: Advanced Gynecology, the Atlanta Breast Care, the Komen Breast Cancer Foundation, and what else do we have here? We have the resources listed here, but we also have Sisters by Choice. So before we really close out, tell us the inspiration for the founding of Sisters by Choice, Dr. Phillips-Reed.
Sisters by Choice was started almost 30 plus years ago. And at the time, there were just a few support groups around, and one that was prominent was support group with the American Cancer Society. And they were doing an excellent job. And there was also a time that, when you went in the hospital for take care of your breasts, again, we were doing mastectomy. So women stayed in the hospital at that time, believe it or not, they stayed in the hospital a week, to 7 days. And so the ladies from the American Cancer Society, they would come by and visit my patients. Majority of the ladies that came by, they were predominantly white, elder, middle-aged women. And my patients felt that they really and truly did not relate to, these ladies. In addition, I was taking care of women who were homosexual, and they just felt that they just did not connect. And so it was at the urgency of my patients that they wanted me to start a support group. And so we started out as a support group at the urgency of my patients, and they got Sisters by Choice because we threw out, let's name it, and everybody threw in, their own, what they wanted to call the support group, and we decided on Sisters by Choice. And the meaning behind Sisters by Choice is that they did not have a choice in getting this disease, but they wanted to join together to fight this disease. So it's Sisters by Choice. And we initially started out as a support group supporting, women with breast cancer. And we extended it to, we had a support group of children of women who had breast support group. And one of my men decided he wanted to have a support group. So for a short period of time, we had men who were diagnosed, wives were diagnosed with breast cancer. So we had all of that under the umbrella of Sisters by Choice. And our focus initially was just to educate the public about breast cancer. And over the years, it has evolved into an organization that will not only educate women with breast cancer, but our main goal is to reach out to women who are indigent and do not have insurance to get the basic screening mammogram. So we try and provide, we have always provided mammograms for women living in shelters, women who do not have insurance. And so we continue to do that. We're a small organization, but we think we do a pretty good job in serving this community with, different services. And, we're developing a chapter at University of Arkansas. They have approached me to develop a chapter of that. So I'm proud about that. So within the next 6 months, we will start a chapter at the University of Arkansas.
Wow. That's great. Congratulations. And so we've come to coming to a close, but before we close, I just want to thank you both for your time, but ask you if there's any, we talked about so many different things as it relates to breast cancer and breast health. Is there a big message for you? Is there a particular message that you want to leave with our audience today before we close? Either of you, or both of you, actually.
I think one of the things that I would like all women to love themselves enough to really and truly take good care of themselves. And it's not just the breast health. I mean, we traditionally have been, taking care of everybody else's needs. Yes. But we really and truly need to put our health issues, breast, because it's, one of the leading cancers that we deal with. But all our health issues need to be put, up front, and we need to deal with that. The old saying is you can't take care of someone effectively not unless you take care of yourself. So I just hope and pray that we as women, love, ourselves enough to put, our health issues, number one in our lives.
Definitely. Thank you. Dr. Contessa?
And I always say food is medicine, and, your health is your wealth. And so I know we have this cultural thing about being big and beautiful, but there is no different scale for being overweight and obese. And so we really have to treat that as though it's a disease, because it really is a diagnosis and it's a disease. And you have to understand that it's a tremendous risk factor for breast cancer. And so if you are not exercising 150 minutes a week, If you're not eating mostly a plant-based diet, doing your best to make sure that the food that you put in your mouth, you can recognize it very easily where it came from. Vegetables should look like it came straight from the tree. So it don't need to come out of a can. It doesn't need to be overcooked where you can't even tell really what it is. And do your best to eat for, the nutrients in the food and not all about the savory taste of it. And if you do that, I think there's a lot of, diseases, different types of cancer, heart disease, diabetes, all those things that unfortunately disproportionately affect our community. And it's not always genetics. A lot of times it's lifestyle. And there's a whole component of medicine called lifestyle medicine. And that's actually one of the things I practice. And I'm kind of in this argument, this discussion, I'm in the minority because, when you go into the doctor, people are uncomfortable about talking about weight with Black people because they get very sensitive. But then, when we write the things in the chart, one of the things we put down in your diagnosis is overweight and obese. We never addressed it with you. So I'm just telling you what we say behind closed doors. When we talk about you and the chart, we always talk about that as being a risk factor. And when these things come up, so I like to tell you in advance, whatever you can do to make sure that you're living your best, for your body, for your blood vessels, for your cells, do that.
Thank you. Thank you. I will say we have to close now, but I can continue talking to you guys all night. But on behalf of the Camellia Rose chapter of the Links Incorporated, thank you so much for your time, for your knowledge, for your expertise, and for your personal sharing. And just want to encourage everyone out there, if you have not gotten your mammogram, if you do not do your self-checks at home, please do that and continue to eat right and do everything you can to be healthy. Thanks, everyone.
Thank you. Appreciate you guys.
Thank you, guys.